Jay ZARKAR is there? Yes, please.
Good morning. Should I start?
Yeah, 4 minutes. Yes.
Good morning. My case is a rare case presentation of ocular tuberculosis and bilateral conjunctival and retinal granuloma. So, introduction: tuberculosis is the leading infectious cause of morbidity and mortality worldwide, with significant prevalence in developing countries. However, extrapulmonary manifestation can be seldom seen in a few patients with disseminated tuberculosis or with localized disease. This manifestation depends on various comorbidity and immune status of the patients. The clinical presentation of the extrapulmonary TB is atypical and can be challenging to confirm, often leading to delayed diagnosis and treatment. This is particularly true with ocular TB. We present a rare case of ocular tuberculosis with bilateral conjunctival and retinal granuloma. My patient is a 26-year-old patient with the chief complaint of growth in both the eyes from past 2 years and gradual diminution of vision in both eyes since past 1 year. No history of similar complaints in the past, no history of any systemic illness or skin conditions, no past ocular history, ocular medication history, systemic medications, comorbidities or allergies. Personal history: no history of any addictions, vegetarian diet. No history of similar complaints in the family. On examination, he was well oriented and moderately built. Vitals were normal and systemic examination was normal. Vision was 612, both the eyes improving till 6.9 with +1 diopter, and near vision was 9.8. On slit lamp examination, in the right eye, there was irregular growth of size 9 mm by 5 mm by 4 mm in inferior fornix. In left eye, it was 8 mm, 5 mm, and 4 mm with draining sinus. Rest of the slit lamp was normal. In posterior segment, in the right eye, in the periphery, there was a yellowish mass at 6 o'clock position of the size 3 disc diopters, which was suggestive of choroidal granuloma. So clinical suspicion of ocular tuberculosis was made. Montos test was positive, but chest X-ray showed no evidence of pulmonary tuberculosis. An incisional biopsy was done of both conjunctival granuloma specimen and was sent for ZN staining, KOH staining, mycobacterial and fungal culture, which was all negative. The real-time PCR test also showed negative report. On excision of the bilateral granuloma, which was sent for histopath, there was fibrocollagenous tissue lined partially by squamous epithelium with extensive ulceration surrounding by dense acute and chronic inflammatory cell infiltration. So based on the clinical suspicion alone, with histology report and positive Montor test, anti-tuberculosis treatment was started for the and with consultation of the pulmonologist. So post which patient responded well to the treatment, showing regression in the choroidal granuloma. So ocular TB presents as various forms, which can be adnexal, posterior segment, anterior segment, and neurophthal, which makes it difficult to diagnose. So in conclusion, ocular TB is a rare extrapulmonary form of disease which should be not be underestimated, considering its potential impact on the visual loss in the patient diagnosed with the disease. It still represents a major diagnostic and therapeutic challenge due to its heterogeneous clinical manifestation, mixed ocular tissue involvement, lack of diagnostic criteria, affordability of the gold standard test, and therefore, as an ophthalmologist, we should always have a TB in our mind while evaluating a patient. Thank you.
Thank you, Dr. Jay. Nice presentation. I have one question. Mantu, what was the value? You told it is positive.
More than 10, sir.
How much? More than 10 minutes?
So,
in particular, this case?
11. It was 11, sir.
11 is a little more than. Okay, so you did not give steroid in this case, only ATT?
Sorry, sir?
Steroids, oral?
Steroids was not given, only ATT.
Okay, thank you.